evening, everyone. Welcome to this webinar. And our speaker, Dr. Bhargavi, is also here. Myself, Dr. Mansi Vishal. I work as Senior Lab Genetic Counselor at Unigenome, which is a molecular biology division of Unipath Laboratory. So I'll just introduce our speaker. Just to introduce about Unigenome. It is a molecular biology division of Unipath Lab. The key achievements are, it is the first lab in India with the highest number of tests which are NABL accredited. Comprehensive expertise is there across different domains of genetics, which is molecular biology, assays, next generation sequencing, NIPT, transplant immunology, cytogenetics, microarray technologies, and pre-implantation genetic testing. With that, there is a comprehensive genomic services portfolio which includes clinical genomic applications as well as research genomics. And there are there is actually plethora of areas including cardiology, oncology, reproductive biology, and rare diseases. So, to introduce our speaker, today's speaker, Dr. Srifani Bhargavi. She is an MBBS, DNB Pediatrics, and she holds FNB in Pediatric Cardiology. Right now, she is a consultant Pediatric Cardiology at Rainbow Children's Heart Institute, Hyderabad. And she has 10 years of experience in the field of Pediatric Cardiology. Her expertise actually holds towards fetal cardiology. She will tell us more about that. Her focus of practice is prevention of heart disorders and prompt diagnosis and family counseling. She holds Best Paper Presentation Award at national and international conferences. Till date, she has 13 published articles to her credit. She will take us towards this topic of impact of genetics in cardiology from fetal life onwards. It's over to you, Dr. Bhargavi.
Yeah. Hello everyone. Good evening all. So today we are discussing of the cardiac perspective or pediatric cardiac perspective of the genetic assessment. So my screen is visible, Dr. Mansi?
Yes, Dr. Bhargavi, your screen is visible. I will just tell one thing in between, sorry. So it is for the audience. So first we will listen to Dr. Bhargavi, and if you have questions, chat box is open. You can write your questions in the chat box and we will take it at the end of the talk. Yeah, over to you, Dr. Bhargavi.
Yeah, thank you. So this topic is mainly about the cardiac genetic assessment starting from fetal life onwards. So we know that there is a prevalence of, my screen is visible or?
So your whole screen is visible. We can see multiple screens on your
Yeah, that's why I'm asking.
Okay, maybe you can stop share and share it again.
Okay. I don't know, multiple screens came. Now?
Yes, now you're, yes.
Yeah.
You can just double click on your screen, Dr. Bhargavi, so that we can only see. Yeah. Now it's good.
Yeah. So we know the congenital heart disease prevalence is about 8 to 10 per 1,000 live births. That means 1% of the live births will have a congenital heart disease, which is a major entity. So when you take a chromosomal anomalies, 30% of the children with chromosomal anomalies can have CHDs. So this is actually a circulation paper which tells about the genetic basis of congenital heart disease. So the main question is why we need a genetic testing for a CHD. Means you know there is a VST or AV canal defect or there is a truncus arteriosus. What is the need? So the need is to know about the pathobiological basis. For example, in hypertrophic cardiomyopathy or long QT channelopathies, to know the pathobiological basis and to risk stratify. And if there are any extra cardiac anomalies associated with this gene, that is important. And to know the prognosis and the genetic reproductive risks of that patient or fetus when becomes adult. And most important thing, the neglected part of the genetic is family screening. We know that there is a heart disease or there is a genetic problem in a baby. We live like that and we will only treat that baby, but we have to see as a family. So when coming to the mode of inheritance of genetic disorders in CHD also, it is same like chromosomal, Mendelian, single gene defects, mitochondrial and polygenic. Most of the reason of congenital heart disease is multifactorial, and the environment and the genes both has impact for the incidence of the CHDs. So the disorders can be like inherited like aneuploidies, monosomies, trisomies, or copy number variations, what we see deletions and duplications like in Di-George-Williams, or the point gene mutations. So these are all the things how the mode of inheritance and spectrum of genetic disorders happen. So when we come to like specific syndromes like Edward, Patau or Down syndrome, the percentage of the heart diseases are high, 80%, 100%. These are all the syndromic specification of the percentage of the congenital heart defects. So there is a paper in 2020 in Genetics and Medicine. This shows, this is actually the largest series. What they have done is from 2012 to 2016, they have extracted the data of fetus with severe CHDs. So there are about 920 fetuses which were identified having CHD, and they have done the genetic evaluation. In that 920, 210 cases about are aneuploidies. So after removing the aneuploidy also, there are copy number variations of around 10% of them are there. So why we are talking about this is, what is the test we should do and when we have to do. This is most important. Nowadays the first trimester screening, inclusion of the NT scan, maternal pap protein A and beta HCG is done for all. In the first trimester, less than 10 weeks itself, we are doing this screening to understand the risk of the trisomies. So alpha fetoprotein also can be done in something. Sometimes NIPT is done. So the couples which those don't allow for the amnio or invasive, we can do a non-invasive prenatal testing. This is called as cell-free DNA, cfDNA, which is 99% sensitive for trisomy 21. But this is only basically for the trisomy 2 identification. So the question here in this study, the prevalence of genetic disease in severe CHD, they have ruled out the trisomies like aneuploidies of 2 level, but still almost 10% have copy number variation and 5% had some chromosomal microarray positive. So these 15% of the patients are diagnosed again either with chromosomal microarray analysis and FISH. So when to go for these is our main concern. So how to do? So we will go as a case-based approach. See, we have a fetus which is of 18 weeks of gestation, primary mother, non-consanguineous marriage. So we can, I think the audience are gynec, fetal and pediatricians. So this is actually the fetal image of the heart showing there is a large AST like common atrium, primum, septum also, and there is a large inlet VST. So this is called as AV canal defect, atrioventricular canal defect, and it is a complete AV canal defect. So what is the approach? When you see in 18 weeks of gestation and AV canal defect in the fetus, what are the things you want to see? So go back to your first trimester, what happened, screening, if you have the records, what is the NT scan, what is the nuchal thickness, and did they do any NIPT, then it's better to offer amniocentesis. because these AV canal defect are most of the time trisomy 21. So almost 60% of the cases. So here the same patient underwent the trisomy amnio and then we have done the karyotyping. It shows trisomy 21 positive. So now I have two things. So this is trisomy 21 and it is a Down syndrome. If you have got a balanced translocation or the same couple, I told as a primary, but has recurrent pregnancy losses, what will be your approach? Here, there is an important thing to know is when you have this type of balanced translocation or couple with recurrent pregnancy loss, better to do a parental karyotyping. So don't stop there at the fetus level. Do a karyotyping for the parents also to identify any hidden translocation in the parents so that we can understand how it is through the family it is coming. And if there is a mosaic pattern means in some cells there is a trisomy, in some cells it's normal, then no need of doing a parental karyotyping. Only when there is a translocation, then we have to do a parental karyotyping. So another case, we had a primary mother, this also 22 weeks of gestation, consanguineous marriage. So here we can appreciate that there is heart is moving but very slow compared to last time. So there is a ventricular dysfunction significant and there is a ventricular septal defect also. So in this case, what is our approach? So the second picture also shows there is lot of AV valve regurgitation. So here comes when there is a fetus with ventricular dysfunction and you are not knowing what is the cause, we have to deal whenever there is a genetics, you try to make a 3 generation pedigree. That is very, very important to know what is the genetic preference and how the disease process is going on. For example, in this family, we can see that it's a consanguineous marriage and there are some deaths in the family, early deaths, and this is a primary mother. So when we have done the genetic evaluation, so it came tapped to mutation gene positive, which is heterozygous but autosomal dominant, and this gene causes multiple congenital heart defects, like we have diagnosed a VSD here with inlet extension, and also it carries an arrhythmia responsible and ventricular dysfunction. So here in this setting, we have to counsel the family, and need of family screening is there because the pedigree shows there are sudden deaths in the family at an young age. So these are very important to consider the family screening and the pedigree in these cases. So next we can go to the next case. So we had another 20 weeks of gestation fetus. They came, there is a first trimester screening which is trisomy 21 1:16 risk, not like very high risk. So because of that they came. So but what is happening is this is a 4-chamber heart. We are seeing some extra flow here. Extra means there is so much of flow going on here. So then what we have done is we have doing the arch views. This is called as pulmonary artery. It goes descending aorta, ductus arteriosus and descending aorta, and this is a aortic arch. But everything is like tortuous, twisted. So when you have a twist of the vessels like this, so we have to think about other disorders. Here only the first trimester screening, what I was telling about trisomies only. But the Down syndrome, Patau, Edward will not cause this type of thing. So then we have to think what is happening to this child. So here what we have done, we have sent the we have done amniocentesis and sent for a whole exome sequencing, stating the features what we have seen. So just writing amniocentesis and whole exome doesn't change anything. We will not get any diagnosis properly. So we have to write our clinical diagnosis or what we are seeing as an imaging purpose. There are tortuous of the vessels. How is the bones from the fetal medicine part? We have to understand and we have to write it so that they can also see a specific genes. So here what happened when we have sent with all the clinical diagnosis of our like arterial tortuosity. So they have run the test and it came as Cutix laxa type 1B positive. which is an autosomal recessive inheritance. So most of the congenital heart diseases are autosomal dominant. Rare to have a recessive, but it has a very lethal prognosis also when you have this type. So these are very rare to report. Only 2 case reports are there, both in one single family. So it's very severe type phenotype of cutis laxa type 1b. You have laxity of skin, bones will be very flexible, and the arteries are also very flexible and they can't survive. So the importance here is what type of test you have to send, you have to understand. Doing an amnio and sending chromosomal microarray doesn't reach your diagnosis, or karyotyping doesn't reach your diagnosis. Here we have to send a whole exome to understand the gene status. So same thing, now we'll come to a baby. We had a 2 months old baby. First child, history wise, first child had passed away at 7 months, second child is normal. This is the third baby, 2 months, presented with significant tachypnea, breathing difficulty, and we will see the ECG. It is called as left ventricular hypertrophy. So during pregnancy, because the first child had passed away and second child is also normal, they have evaluated for any cardiac illness. Fetal echo was done, which was normal. So, but the fetal medicine person has done a CVS biopsy and they have sent enzyme assay. So this enzyme assay, normally it's of alpha glucosidase, which should be like 132, and it's like in the range, they thought, and this one is 390, this is also in the range. So but after birth, again we saw that there is a left ventricular hypertrophy significant, and we have sent the same enzyme assay, and which was very low. This is called as Pompe's. So Pompe's disease, same alpha glucosidase enzyme 2.9 is very low. So here my question is, where is the fault? They have done the enzyme assay also during fetal life CVS, but still we gave a baby with Pompe disease. So here the main important thing is, whenever you see a Pompe's also, don't stop at enzyme assay, do a GAG-gene analysis. So we will know the gene, and it's better to do a gene analysis also of the same single variant, so that we'll understand the transmission. So this is most important. That is the reason we have placed, I am showing this case. So doing only enzyme is not enough. Go for the gene and then test the gene in the amnio. Good thing is we have to counsel the family. It's a genetic and it should be followed up, and the amniocentesis should be done, and we have to see the gene. So like this only, we had another family of hypertrophic cardiomyopathy. So whole family, there is from the paternal end, there are many deaths because of HOCM, and then father is also HOCM. So he was identified at 8 years of age, and his gene was positive. It is MYH7 gene, which is likely pathogenic and autosomal dominant, and he had recurrent episodes of syncope, so underwent ICD, defibrillator placement. And here the importance is, when you see the gene, if you have a myosin bind chain gene MYBC and MYH7, you have to consider MYH7 is more lethal gene. So this couple came to us when the first pregnancy time. So we have tested the fetus amnio, and then we had that there is a gene, MYH7 gene, again positive in the fetus. So, but when you see a fetal echo, you are not seeing any ventricular hypertrophy here. So everything is normal. There is no ventricular hypertrophy, heart function is normal, everything is normal. So these are the tissue Dopplers we took during fetal life. Those are also normal. So the important thing is how to counsel the family here. You have index father is a gene positive, and the fetus when you did amnio is also gene positive, but in fetal echo it's a normal, no LVH. So the main purpose why I am telling is, hypertrophic cardiomyopathy phenotypically may not manifest in the fetal life or even in the initial infancy period. LVH will slowly develop and they will have symptomatology, mostly around 10 years of age. So we have to discuss with the family that there is a gene positivity is there, and we have to counsel them about the probabilities of again having LVH, hypertrophic cardiomyopathy, and going for arrhythmias to the fetus also in the later time of the fetal life or the childhood. So these things we have to counsel as an engulf family, and then the family has to take decision. So this is very important because there will be no hypertrophy and fetal echo will be normal in these type of things, but when you do amniocentesis there will be gene positive. So these are the important lessons that we learn. So for example, we'll come to other situations like structural heart diseases. You have a structural heart disease and we can see there is a loss of offset. Many of the times fetal medicine or pediatric cardiologist will write like loss of offset. What is the loss of offset means? It's about the endocardial cushion defects. There is a primum AST here and the both AV valves are at the same level. Okay, so it is again called as AV canal defect of primum AST. So here also it's important to know about the genetics. So here we have done the genetics and the karyotype was negative. So this child has born now almost 2 years of life, only primum AST and doing pretty well. So these are the conditions where we have to do the genetic testing. So sometimes we'll have a perimembrane. So if I say the VSTs, which type of VST should undergo amniocentesis, which should not undergo amniocentesis. So when you do see like this, if there is a perimembranous VST or there is a muscular VSTs, no need of going an invasive test. Just see your all the reports of NT first trimester screening, that is normal. So if your nasal bone is normal, NT scan is normal, only there is a perimembranous or muscular VST, no need to go for the invasive testings. But if you have a AV canal type of VST, that means inlet type of VST, definitely we have to rule out the trisomies. So this is very important case. We had a 26-week fetus with very bad obstetric history, now third gravida, and we can see the heart is floating. So there is lot of pericardial effusion. Another thing we can see that there is so much of whiteness, hyperechogenicity of the vessels. Even the descending aorta is also more of hyperechogenicity. So here again it comes like we did pericardiocentesis, we removed the fluid. Here we can see their heart is not floating, but there is a ventricular dysfunction. There is hyperechogenicity of the whitish of the heart. So here again there is a suspicion called as fetal arterial calcification syndrome based on the clinical variants. So we have sent again the genetic whole exome sequencing. So we got the gene positive. So these are the cases where we have to send specifically, think about the diagnosis and send specific gene analysis. So when we are writing also, it's like whole exome sequencing, but we have to write our clinical diagnosis so that it will be understandable what we are thinking as a physicians. So it's an idiopathic arterial calcification. So sometimes I will show some cases where we done amniocentesis but everything came negative. These are most of the time tetralogy of Fallot with good antegrade flow across pulmonary artery and pulmonary valve, and there is also thymus and left arch. So why I am telling thymus left arch? Whenever we think of tetralogy of Fallot, we think about Digeot syndrome. But if you are seeing a thymus shadow in fetal life, fetal scans, and there is a left-sided aortic arch, the incidence of Digeot syndrome comes down. If you have a right arch, then the incidence increases to 30%. But if you have a left arch, incidence decreases. So here the things are not only sending an amniocentesis or sending a chromosomal microarray, we have to note the points, which side is the arch, is the thymus is there or not, so that we can counsel them in a better way. Because most of the time they may not couple or parents will not agree for the invasive testings also. But if you have pulmonary blood flow is not good, atresia, VST pulmonary atresia, right-sided aortic arch, thymus is not clear, definitely we have to counsel them and make them understand the need of invasive testing and sending for CMA for Digeot syndromes. So it's better to do a chromosomal microarray rather than a FISH. If you want to do a FISH, you should have all the characteristics of the Digeot syndrome, then only it's better to go for FISH. If you have a doubtful, better is chromosomal microarray, which identifies microdeletions also. That is the reason. So sometimes we see isolated right aortic arch. So isolated right aortic arch, it's our experience only, I'm telling. Literature says we should do amnio for everyone to understand the Digeot. But here also, if you have isolated right aortic arch, if the report is saying thymus is there, then you can discuss with the family. So this is the thing, these points are there, and there is an invasive testing. If you are okay, we'll go for the invasive testing, because these are very important to know, because everybody in the family says the risk is there if you are going for invasive testing, but most of the time nothing will happen, but we have to make the confidence and then we have to tell them. So actually this case also we had no significant copy number variations, no deletions or duplications, nothing came positive. So when you have a fetus suspected heart disease, how you want to go? So I would say, if you have a structural heart defect, for example, you have a TA-PVC TGA. So TGA has less than 3% or 3 to maximum 4% of genetic association, not more than that transposition of great arteries have. So transposition of great arteries or total anomalous pulmonary venous return, perimembranous VST, muscular VSTs, there is no need of going for an invasive testing. That is the main thing, because these are not very much associated with the genetics. And next, if you are coming with TOF, left arch or isolated right aortic arch without any congenital heart disease, you can go back and see the things, points, first trimester screening, thymus, counsel the family, you tell about them, discuss with them about the invasive testings, then we can send a chromosomal microarray, not karyotyping in these cases, because we should know which test to send during an amnio. You are poking the mother and sending a wrong test is not correct. Then if you have another subset, you have a family history of congenital heart disease or cardiomyopathies, dilated cardiomyopathy or hypertrophic cardiomyopathy, or you have a rhythm disturbances, sudden cardiac deaths in the family noted, and there is any Brugada syndrome or long QT syndrome in the family running. So then also it's better to do a definitive genetic testing of the suspected mutations we have to send. So you can do an amniocentesis and then you have to write these are the mutations we are suspecting. So either you do a gene analysis, single gene analysis, or what are the genes you wanted to, or send a whole exome, but you have to definitely inform them these are the genes involved in the family. And most important, 3-generation pedigree. That is very important when you are dealing this type of family history, cardiomyopathies, mainly hypertrophic cardiomyopathy, even dilated. So what in our setting, what we do, if I got a child with dilated cardiomyopathy, we rule out first correctable causes of cardiomyopathy. That means nutritional, thiamine, or anemia related causing LV dysfunction, and endocrinal, thyroid, or structural heart disease like Al-Kappa. So these are cooptation. So these are all the mainly the treatable causes of cardiomyopathy, vitamin D3 deficiencies. Then we will see as if not as a patient, as a family. So everything coming is negative. Then we should do ECGs and echoes to the siblings and the parents, at least first degree, so that we'll understand what is happening. Then you send a genetic analysis of the child. If it comes positive, then do a genetic analysis of parents and then we can counsel them for whenever they're having a next child. So amniocentesis, then we can correlate, is this gene is responsible. So start with an index child, do a genetic analysis, then if it comes positive, do in the parents same gene analysis. Then we'll understand, is it a de novo mutation or it's running in the family. Then we can offer them about the amniocentesis. So this is very important because cardiomyopathy will not very rare to present in fetal life. Most of the time after 2 years, after 1 year of age only, the presentation will start. So next, definitively you have to do is AV canal defect and conotruncal anomalies. Conotruncal anomalies means your truncus arteriosus, VST pulmonary atresia with right artery. In these cases, it's a definitive thing of going for amniocentesis and sending a chromosomal microarray. Sometimes you have clinical picture of syndrome. For example, you have a VST pulmonary atresia, right aortic arch, pulmonary arteries are very small and thymus is not seen. You have sent a chromosomal microarray, it comes negative. Then what should we do? So the paper which I shown first, the fetal of 920, have the same thing. They had chromosomal microarray negative in some clinically suspected cases. Then they have done exome. Then in exome it came positive. Almost there is a difference of 10%. So these are the things to be remembered. So we have to, if your clinically suspicion is more, then better to talk to the genetic person who is dealing at the lab. Share your experience. This is what I am suspecting. Then we will have a proper diagnosis. So my conclusion is, so 3-generation pedigree, focus on your first trimester screening, what they have done and what is the need, why they came for you as a cardiologist here, and interpreting all the reports, clinical, echo and the genetic data. So most of the time we have a problem. Actually, I used to have so much problem. VUS means variant of unknown significance. So whenever we got VUS, we leave the report. But don't do like that. When you have a variant of unknown significance and that same gene is clinically correlating with everything, because they state that this gene causes these problems and your clinical correlation is same, so it's not a VUS. VUS is because it's not reported very high, so it goes into variant of unknown significance. Here we have to think about it's a significant, and again talk with your genetic person sitting in the lab and they will make us understand in a better way. So my main thing is, don't consider the fetus or patient as alone in single unit. You consider whole family as a unit and then do the genetic testing to have a proper diagnosis. Then only we can counsel the family in a better way. And I want to say, if genetic positive means termination, it's not correct. We have the things to deal. So many times we can discuss with the family. They will have a better life. You tell for and against, and the family can choose whatever they want. So I thank you for everyone's patient listening.
Thank you, Dr. Bhargavi. This was an enlightening talk. It included clinical genetics, genetic testing, and the fetal cardiology as well. So the forum is open for questions. Please ask as many as questions you want. We have an expert today, and we can ask all the queries, and she can answer. She can enlighten us more.
This is
So I have one question, Dr. Bhargavi. So you mentioned that first CMA should be done, and then if it is negative, then exome can also be done further. Like for this last patient, you told us that it came positive in exome test, but it was negative on CMA. But how to decide? Because sometimes you must be seeing that we have less time for genetic testing in the pregnancy. So how do you decide?
See, actually, that paper showed. Actually, we did not do exome for that child.
Okay.
So, but actually, it's a very good question. That's what we have very less time till 24 weeks of gestation only. So, we have to decide, we have to do amnio, we have to get the report before 24 weeks to do anything. So, here, important thing is that's what if you have specifically, you have a right arch, no thymus, and all the clinical means we should see as in whole. Any extra cardiac anomalies are there? Are they fitting in there? If everything are there, you do a chromosomal microarray. That's a better thing. No need for the whole exome genome sequencing. Only thing is, we have to, as a physician, I have to write in that paper properly what we want.
Yes.
What is our clinical? Then I think it's better you will understand what we need and then report will come. That's what I understood.
This was a very good point which you highlighted actually, that even if you are sending for chromosomal microarray or whole exome, the clinical suspicion you have, so that needs to be written, and like as much clinical history as you can give to the lab.
It's not only for the fetal, anywhere. That's what, for a child or adult also better to write all the clinical suspicions.
And as a lab, we also face many difficulties when there is less clinical history, because there is an understanding, I guess, that if we are sending for whole exome or a chromosomal microarray, then everything will be covered. So even if we don't give clinical history, that should be fine.
Yes, that's what everybody thinks, but
you are muted.
Yeah. So, but everybody thinks that with one test everything comes without any clinical assessment, but that's wrong. And I want to highlight another thing: whole exome sequencing is different, whole genome sequencing are different. Both are different. You will not have all the genes. Am I correct, Mansi? If I'm not wrong.
Yes. Yeah, you are right. You are right, Dr. Bhargavi.
Yes. And the whole exome sequencing needs more clinical details because they related genes only they do.
Yes. So even if we are it is whole exome test, the library preparation is for the whole, but clinical history always helps in searching for the right genes. Sometimes we can miss the gene if less clinical history is there. Yeah. So we have few questions in the chat box. So Dr. Firoz has asked about TSC gene variant and its significance in a 2-year kid with rhabdomyoma. Please share your views.
Yeah. So when you are seeing rhabdomyoma, and that means there is a skin manifestation, cardiac, and also neurological manifestations. So nowadays rhabdomyoma has very good treatment. So we have mTOR inhibitors which can regress our cardiac rhabdomyomas, which can regress neurological also masses, and the infantile spasms can come down. So we have almost 15 cases of cardiac rhabdomyomas in the 10 gene positive. They are all doing well. So I think the 2 years old child will do well. If any infantile spasms are there also with vigabatrin and mTOR inhibitors, they do pretty well. They will have a normal life.
He's further asking how important it is to monitor the size.
So there, when we have to give mTOR inhibitors is important. So when you have a significant cardiac mass causing arrhythmias or outflow tract obstructions or inflow obstructions, then we should give mTOR inhibitors, or else no need. So the monitoring part is every 3 to 6 months. If there are small masses not causing anything, you monitor every 6 months with echo and also ECG. Both should be done.
Okay, I hope it answers your question, Dr. Firoz. So we have more questions from other, yes, he got the answer. So Dr. Sarjan Shah is asking, how are you addressing VUSs?
My addressing of VUSs is, if my clinical and the gene is correlating, I will call the lab. That's what I do first. So that's very important. Talk to them and tell my clinically it's very correlating. Then they will tell you can address in ClinVar the website so that it will be, if more reports comes of VUS with clinical significance, then it becomes too likely pathogenic. That's what I understood by genetic, and Mansi should tell me.
Yeah, so as the data is getting updated in the databases, in the global databases, we can address the VUSs. Sometimes, like after doing some research, we get to know that okay, this VUS is not important, so it needs to be addressed that way. If we are not sure whether it is not, like whether it is having any clinical significance, it is correlating a little bit clinically, then we can do co-segregation analysis also to further see whether this VUS is holding any importance. But prenatally, so as per the guidelines, based on a VUS, we cannot take any clinical decision. Yeah, unless we really think that okay, this VUS is like some promise, it is promising and it is showing some clinical significance, it is segregating with those family members where clinically it is showing up also, then only we can. So it will vary from case to case, as Dr. Bhargavi will agree with me.
Yes, case to case base, and the clinical findings, you have to have correlation with that gene.
Yes.
Then only take it as significance, or else I don't think it's a significant gene.
Yes. So Dr. Badri Dandapani is asking, what is the ideal approach starting from fetal life to till birth? Many a times fetal echo and finding after birth varying and relatives are anxious.
Yeah. See, in fetal echo, intracardiac echogenic focus is normal. It's not related to the trisomy. You go and see NT scan is normal. Don't go for the trisomy. Coming to the ventricular septal defects, inlet VSTs we can diagnose, muscular and perimembranous. Perimembranous, large defects to moderate we can diagnose, but small fetal echo also can't diagnose. When you're counseling, we have to tell them it's 95% sensitive, because small perimembranous, small muscular VSTs, nothing will happen at the end. It will obviously close up postnatally. That's what I think you are asking, because we tell there is a VST in the prenatal time, and postnatally after 2 weeks or 6 weeks of time it will be closed. So we have to counsel the family that is it structurally normal heart, or we have a small doubt about VST, that automatically closes. No need to make them very anxious about that. So coming to a structural heart diseases like tetralogy and all, we can explain them the need of surgery, TA, PVC, TGA, and most of the families will agree, because they do pretty well, and you can show the examples of the cases you have.
So he's Dr. Badri is further asking that when to advise exome sequencing and when to do genome sequencing. Do we do genome sequencing here?
Genome sequencing is done very rare actually. So in the fetus also, that's what I want to say. If you have an AV canal defect, structural heart problems, which you know these are due to trisomies, do just a normal karyotyping and assessment of trisomy. If you think this is a di-George variant, do a chromosomal microarray, or Williams you are suspecting, allegedly you are suspecting those things, and do exome only specifically. Don't go to the battery of the tests. Based on the clinical only we have to do. And whole genome, I don't think many are doing, and no need when you have a clinical diagnosis. Most of the cardiac we will have on chromosome, means depending on the aneuploidies, deletions, duplications, or single gene, thinking single gene, then exome is okay.
Thank you. So Mr. Prafulla is asking, previously used to do newborn screening followed by enzyme test. Now Max going for whole exome sequencing. What is your opinion? I did not get his question.
Yeah, I understood. So Prafulla, actually, I think all the babies are subjected to newborn screening. Then there is an extended newborn screening where mitochondrial is also added. So here also clinically we should decide. Newborn screening is must for everybody. But if you have any family history of sudden deaths and suspecting a mitochondrial disorder, then do an extended one. No need for whole exome sequencing for all. If you have a clinical correlation, if there is a clinical indication only, you go for it. But as a routine, no need for all whole exome sequencing.
So another audience person is asking, PGS should identify fetuses at high risk for CHDs? I think he's asking whether pre-implantation genetic testing could identify fetuses at high risk for CHD.
I think Mansi should answer this one. I think they can identify. That's what when you are going for IVF and all, they do pre-genetic testing. Then only they implant.
Yes, pre-implantation. Yes. So few will be covered in that, but we cannot be sure that overall it will cover everything. But yes, that will be a promising test when somebody is going for IVF pregnancy, or then pre-implantation genomic screening can be done for CHDs. Yes, like you explained about trisomies and other VSDs. So yes, that can be done. Right.
So I think in recurrent pregnancy loss also, bad obstetric history, they do pre-genetics.
Yes. Mostly when people have RPS, so they go for it. So whenever there is a past history, people would actually, it is more we can say recommended in those cases when there is some past history or some history in the family, or there is a case of RPL. But yes, if in general for all, I'm not sure.
Yeah.
So yeah, there was one more question. So Dr. Badri is asking how you approach a case of LV dysfunction without structural anomalies like COA, ALC, APA in neonatal period.
Yeah. So if I have a LV dysfunction in a neonate or infant without any treatable causes, means considering everything like structurally normal heart, no thyroid anomalies or nutritional deficiencies, I will do I'll see first the ECG. So ECG voltages, how are there? That is very important to see, are there low voltages or not. And then we routinely do newborn screening to understand the carnitine before starting the L-carnitine. So many times they may have a carnitine deficiency. In the ECG, you will have uniformly tall T waves in that one. So that is a need for ECG. So see your acidosis part, any hypoglycemia and acidosis is there, then definitely you go for newborn screening for fatty oxidation defects and all. Then we have to do family ECGs and echoes. Then we routinely send whole exome, considering all the clinical history and 3-degree generation pedigree. So we'll understand any running in the families. So these are the tests what we do.
Okay, thank you. So Mr. Deepak is asking if we suspect. You have read the question.
Yes. If we suspect hydrops fetalis in a second trimester, and we are seeing there is no other causes, like no AV fistulas are there or vein of Galen is there and no structural problems are there, then it's better to go whole exome sequencing rather than going for chromosomal microarray karyotyping and waiting for it. Why? Because trisomies means there are Down syndromes can cause hydrops fetalis, but if you have an NT normal, nasal bone is there, no inlet VSTs, then we are ruling out most of the time Down syndrome. So that can be a single gene defects and all, which we will get from VUS. So doing a chromosomal microarray or karyotyping, waiting for the result and sending exome is, I think we are delaying the time when there is a hydrops.
Thank you, Dr. Bhargavi. If you have more questions, you can still write in the chat box. So overall, doctor's talk highlighted the importance of clinical history, the importance of counseling. So the thing which I liked was being a doctor also, you always emphasized upon family counseling, talking to the families in between about the genetic testing. And it is a very important aspect of genetic testing, I guess. So in your clinical workup, in between, so in every step you are talking to the family, explaining them what are the expectations from genetic test results, and then you are proceeding with the genetic testing.
Yes, that is more important, or else without their confidence we can't do anything.
Yeah, that's true.
Good evening, Dr. Bhargavi. What a lovely talk. I think it has clarified a lot of doubts of our clinicians and upgraded them to take care of the fetal heart as well in a much better manner. Wonderful talk once again, and thank you, Dr. Mansi, for anchoring. I just wanted to add a few lines about the PGT question that was raised. So if you give me permission, I'll just go ahead.
Yeah, definitely.
Thank you. Thank you so much. So pre-implantation genetic testing is a modern solution to rule out chromosomal abnormalities, single gene abnormalities in the embryonic stage itself before implanting them on the endometrium. So if genetic basis of a congenital heart disorder or any heart disorder for that matter is established, and we have proper diagnosis, so we know if there's a single gene disorder that's causing a heart disorder in the family, then we can definitely go for pre-implantation genetic testing for monogenic disorders. So that's a special type of PGT where we need to do a couple workup, first of all, to find out which allele has that mutation, and once the pre-implantation genetic testing of the couple workup is done, then we go for the embryonic testing by taking few cells from the trophectoderm biopsy and doing a complete analysis for those mutations which were found in the index case for which the genetic diagnosis is established, and we can rule out those disorders with a very high sensitivity and then choose an embryo which either is a carrier or completely normal for an implantation. So by that we can rule out that genetic disorder before implantation. So that's very much possible today, but for that genetic basis of that disorder has to be first established. And pre-implantation genetic testing for recurrent pregnancy loss is also very much in need and in practice today, especially for females with increased maternal age and undergoing recurrent implantation failures or pregnancy losses. We can use pre-implantation genetic testing for aneuploidies, where utilizing the trophectoderm biopsy once again, we can check for chromosomal errors, either unbalanced translocations or trisomies or monosomies, and pick up an embryo which does not have these errors, so that increases the chances of success in the IVF implantation, and also there are chances that we'll reduce the number of cycles that we have to do for a particular patient. So yes, these modern age technologies are very much available today. Thank you so much for allowing me to answer this question.
Yeah, thank you, Dr. Monica.
Thanks, Dr. Monica. You answered it in detail. And yes, it is a promising technology. Like few years ago, it was a dream. Now it is happening very regularly, PGS or PGT. You can go for it. Just to highlight that at Unipath, all these genetic testing options, like be it chromosomal microarray, be it a cytogenetic test like karyotyping, or all other molecular testing, be it PGS or PGT, it is all offered at Unipath lab. Unigenome is the molecular biology division, but as I'm covering the whole Unipath, where cytogenetics is also part of it. So if there are no more questions, we can end the talk. Dr. Bhargavi, do you have any other thing to say?
No.
Thank you so much. It was very enlightening talk. I'm sure everybody will agree with me. Thank you so much, and have a good night.
Yeah, thanks for the patient listening, everyone.
Thank you so much.
Okay, then good night.
Good night. Thank you.
Good night. Thank you, everyone.
Yeah. Thanks, Dr. Monica.